going to get going. Thanks, David. Okay, welcome to the faculty meeting, the last faculty meeting of the summer. And next week, of course, school starts. So we thought it was a great opportunity to use this faculty meeting to introduce our candidate, Dr. Khumbo Kalua, who is part of an initiative launched by the Provost Office to increase the number of Black faculty at UBC. So we are very fortunate that we were able to get one of the slots, thanks to Dr. Lovato. She championed that case, and thanks to Mika for helping put together the proposal. For some reason, Gage, being from the arts, they had advanced knowledge about this, and the proposal was to hire in cohorts only, a minimum of 3 in a cohort. So the other faculties prepared, and then they put forward cohorts of 3. Medicine couldn't, but we made an argument how we could link with other faculties, and so we were fortunate. The list of people that have been selected can be found in the Provost Office. There was a big announcement. You should look at it. Some very exciting faculty being recruited here. And it's going to be over 4 to 6 years, the recruitment of all 27. I think in the first year, there's only maybe 3 or 4. And we were in that first year basket because we had somebody who was here. And so Dr. Kalua immigrated to Canada recently from Malawi. He's a professor, associate professor in the University of Malawi, and very active in global health. He has a degree, a medical degree from a joint program run by Australian University and University of Malawi. And then later on, he went on, after doing clinical work in ophthalmology, he then went on to the London School of Hygiene and Tropical Medicine, where he did a master's in global health. And then he did some other courses. And then he eventually did a PhD in Epi and global health. And we are very fortunate to be able to attract Dr. Kalua here. And I'm not going to give any more in terms of his background because I asked him to present a little bit about himself and his background, so we'll hear that from him. I don't want to repeat. And then Dr. Kalua will be available to meet with interested faculty who want to talk to him at SBPH from 1:15 to 3. We've set him up 133 or 105, 133, I believe. And that's opposite my and Mika's office. And then you can meet with him. And of course, we have a very important lunch to say thank you to our colleague Mika, who's not going to be my boss. And it's going to be fun. So, welcome.
Thank you very much, and good morning, everyone. Good morning.
Good morning.
Can you hear me?
Yes.
Thank you. So, yes, I'm going to talk this morning in a few slides about global health and Imperial Science research contribute to improvement in the management of neglected diseases in Africa. And I'm going to share with some experiences from Malawi, Southern Africa, where I come from. And I would like to thank the team for inviting me here. And I'll say a little bit about myself in a few slides. So first, I'd like to start by acknowledging the land that we gather in. This is the land of the traditional, ancestral, and ancestral territory of the Masquan people. in terms of my presentation outline, I'm going to talk about a bit of my family background so that you can know me a little bit and my education and my work, which I think has all been spoken about, so I'm not going to talk about that. About my research and teaching, my work on neglected tropical diseases. I'm not going to talk about my work on eye care because I already found out that the head of the department is here, and I thought, well, I didn't expect someone on eye care to be in the group. So that's not going to come out. I'm going to talk about research on neglected tropical diseases, including one eye disease that I started with and how I've extended to the rest of the NTDs. I'm going to talk about clinical trials, Imperial Science that I do, and in conclusion, and finally, I will just say what I think I could contribute to the school and the faculty and invite some questions. So I moved to UBC last year in July with my family. We stay in Richmond, and my children experienced the snow. Very excited. We went to Whistler over Christmas, and my son was so motivated. He's in grade 5 that he did well at school. That he has been selected to start grade 6 at a French immersion school in Richmond. So he told me, Dad, you know, I've made it, you also should make it. My daughter, she's in grade 12 in Richmond. Okay? So before coming here, I still work with the Khumbo University of Health Sciences. This is the only medical school in Malawi. And also I work with the Blantyre Institute for Community Outreach, where I do most of my research. And I said I've been focusing on global health for the last 6 years, initially with global eye health, but since 2016 with a whole range of neglected tropical diseases. 2016 is a landmark for me, because that's the time I got my PhD from the London School of Hygiene and Tropical Medicine, University of London. So it just went up. I could no longer do clinical. So I'm not a clinical ophthalmologist, but I'm a research-related ophthalmologist in terms of research. Through my work, I've been privileged that I was trained as a master trainer by WHO in a range of eye diseases, as well as other ATDs, such that I've been supporting a number of countries in Uganda, Kenya, Tanzania, Zambia, Zimbabwe, up to some countries in Asia, like Myanmar. I've been there training and conducting some people on research. So, as I said, for this talk, consider me trained in global health and Imperial Science. But I started with a medical degree in Australia, in South Australia, University of South Australia, where I was there for 6 years. And because of the diversity, I just wanted to make sure that when I was in the medical school, in the class of 120, we are only 2 black students. So I can tell you in another forum how it feels to be in the minority. As you know, Australia has also got the First Nations, the Aboriginals, and they were doing Aboriginal studies, many of them at the university, trying to find out the systemic things that had happened to their culture. And so you see a lot of people and they assume that you are doing Aboriginal studies. You say, I'm doing medicine. He says, why are you doing medicine? So I stayed there for 5 years and then had to go back to my country where I practiced a bit. And while in Australia, I did pick up some interest in a community because there was a well-known professor, Professor Freddie Horace. He was doing a trachoma work in the Aboriginal areas, and I just got excited that I wanted to do that. But to do that, I realized that I needed to do ophthalmology. So that was now my specialization in ophthalmology, where I did 4 years at the University of Nairobi in Kenya. So I am an ophthalmologist, and I started doing ophthalmology for about 10 years, active ophthalmology, and that's where I got introduced to the global eye health, especially in trachoma, and I was trained as a master trainer in trachoma, and the rest is a story where now I've just moved in to the whole global health. So to get my skills, since I had a medical background, a clinical background, to get my skills in public health, I had to go to London School of Hygiene and Tropical Medicine, where I did a master's in global health. And when I went back to my country, I was trying to do this research, applying for grants. And when I applied for one grant, worth about $300,000. This is the first grant that I applied. They said that we can give you this grant on condition that you register for a PhD. So I thought, well, I've done a medical degree, I've done ophthalmology, I've done masters. You still want me to do a PhD? But they told me that this PhD, you could be doing it on and off. You don't need to be in London all the time, 6 months, but you can be doing your work. So I ended up doing a PhD in London, infectious diseases, and then over the last 3 years, I've done some Imperial Science work at the University of Washington in Seattle in global health. So I believe I'm equipped as a global health person. In terms of some of the skills I have, I do mixed method research, quantitative and qualitative. I do a bit of clinical trials, epidemiology, and Imperial Science. I have a lot of networking because of the countries that I've been supporting, and I have done some collaborations and leadership. Currently, I sit in a number of WHO sort of initiatives. One of them is called Children Without Worms. This is a body that advises WHO on soil transmitted herpes. I'm going to talk about it later. And I have been lucky with the skills that I got from the London School that I've been able to get a good number of grants. I have at least received a Canadian dollar, about $20 million in grants in total so far. And the last grant that I'm still working on was $7.5 million, and I'm going to present on that study right now. I also try to publish as an academia. I've got 72 publications in peer-reviewed journals, most of them on global health. In terms of teaching, initially I was teaching a lot of clinical ophthalmology, a master's in medicine in ophthalmology. We started a program in Malawi. Over the years, I've started teaching epidemiology and statistics among the ophthalmology students, and also teaching them some clinical sort of global health application. I've also supervised masters and PhD students. And I started an extended program with the University of Waterloo in Ontario with the video sciences. And I was able to attract 4 students a year to come to my department in Malawi and stay with me for 8 weeks. So I needed to commit every year 8 weeks of my time, and I would take up students. This was extremely attractive. But in 2016, I decided I'm going to have the last cohort. So I did not take any extensive students from 2016 because I needed to increase my time on research. So that's when I started focusing on the neglected tropical diseases, just to say that there are 20 that are spoken by the WHO. They are caused by either bacteria, viruses, protozoa, and they affect 1.6 billion people. So with half of them being almost children. So the global population is around 8 billion, 1.6 are affected by these diseases. And the Canadian Network for Neglected Tropical Diseases is an NGO that is based in Ottawa. It actually says that the improvement in global health, the missing part is NTDs. It's not being taken seriously because it's affecting the poor. There have been some efforts. In 2012, the London Declaration in London declared that the NTDs needed to be eliminated by 2020. We didn't achieve this, but there was a lot of effort that was put in, as I'm going to demonstrate to you. But in 2022, in Kigali, Rwanda, there's a new declaration that these NTDs needs to be sorted out by 2030. The Kigali Declaration was a very high-level declaration because King Charles attended, and following that declaration, there's been a lot of commitment of funds towards the NTDs. And WHO has come up with a roadmap for 2030 that is addressing the sustainable development goals as well as the invasive coverage. I'm not going to say so much about the SDGs and UHC because I'm going to have a forum this afternoon, so I could speak about them if you wanted, but only to say that among the sustainable development goals, the goal number 3 talks about health and well-being. And if you go there on 3.3, it talks about eliminating NTDs by 2030. And the goal number 3.8 talks about achieving invasive coverage. So unless you achieve invasive coverage, or unless you eliminate NTD, you are sure that the sustainable development goals are not going to be achieved. This is a range of the 20 diseases that are in the neglected tropical diseases, all of them from the tropics or subtropics, not known by most of you here. because they are neglected. But they are there and they affect about 1.6 billion people. So here is where they are. Maybe I can point now. So you see here, this is a overlap of the entities. So you see here, 6 of them in one area: South America, Africa, yes. And some of them, four of them in one area in Asia. And so they are significant, as a body. Malawi is a small country here, you can see it. So we have about 5 of them in Malawi, and Iweki in all of them. Australia, a developed country, I mentioned about it. It's still got one disease, and that disease is trachoma among the Aboriginals or the First Nations. And that's where I said I started my interest, because I saw Fred Horrors trying to work on these communities. And in 2016, we had the global trachoma conference in Sydney. And we went back to see these communities, and there's indeed still trachoma in Australia among the First Nations. So among the 20, there are these 5. They are called the preventive chemotherapy NTDs. The commonality about them is that they are called drugs that can be given preventing the transmission. So I'll quickly talk about it. We have got the lymphatic filariasis. The vector is a mosquito. The disease is called elephantiasis. We've got trachoma, which I'm going to talk about. The vector is chlamydia, onchocerciasis. Schisto, the vector is a schistomansoni and schistohematobium. Mansoni in the stool and hematobium in the blood. And you've got soil transmitted herpes, the hookworm, roundworm, and gripworm. The vector, Ascaris lumbricoides, Nichet americanus, and ancestoma, transmitting this through the fur. I've said here that these require a mass drug administration, just periodically, less once a year, to eliminate them. But there's still a challenge about these ones. So the NTDs, they are linked to the social determinants of health. Holding said that even in countries like Malawi or Zimbabwe, where the NTDs are supposed to be endemic, among the poor and less educated, the odds ratio of having an NTD is twice as much as if you are educated and not poor. And I've been working as part of the African Research Network for Tropical Diseases to try to just give a visibility to say African researchers can actually work on these ones. And today's topic is going to be on trachoma and STH. So I'm still going to talk about eye care, but very briefly, but I want to talk about the soil-transmitted herpes. Okay. So trachoma is a leading cause of infectious cause of blindness, and is transmitted by the flies. The infection, the chlamydia, goes from one child to the other through flies, and is responsible for 1.7 million people that are blind. And the blindness is associated with inequities and poverty, usually among women and children. And the behavior factors are very important here, because we're talking about the issue of water, sanitation, and hygiene. Unless those are covered, trachoma cannot disappear. This is the picture that I took in one of my community work in Malawi. So this is the real picture of a child that is having flies. Trachoma has been tackled as part of the global health through the Global Trachoma Elimination Project, or the GET 2020 by the WHO. And this is a group of partners that have come together to say we must eliminate this disease. The first thing that we need to do is to determine whether trachoma is of a public health importance. So you have to do surveys at a population level, and that's where my work involves in. So you do surveys at evaluation units of around 250,000 people, and you determine whether there is a trachoma infection in children aged 1 to 9 or in adults. And once you have determined that there is a trachoma infection, then you need to do a full safe strategy, where you need to do the surgeries for the people that are at risk of blindness. You need to give antibiotic, the one that will give is azithromycin, once a year, maybe 1 year or 3 years. I'm going to talk about it. Face washing, environmental, and behavior change, BICC, because unless you change the community behavior, trachoma can continue. Once you've implemented the project, you need to contact impact service, quality of life service to see whether you are making ends. If the impact service show that you're okay, you wait for 6 months, then you continue with WASH. You give 2 years of no antibiotics. After 2 years, you go back, you evaluate whether you have actually eliminated trachoma. And if you think now trachoma is no longer a problem, then you ask the WHO to declare it as eliminated. It's a very tedious process. You have to write a dossier, you have to show that you have surveyed each and every place before the WHO can actually eliminate trachoma. And there are, I'll tell you, not many countries are eliminating it, but I'll show you the way that I'm doing it. So, as I said, that I started in eye care, global eye health. There was a call after the London Declaration that they are looking for people that could be champions to take up research in the trachoma, and I just finished my master's, I have the skills, I said, I'm going to do this. So through the UK government, who gave 10 million pounds for all the countries to survey trachoma, countries were fighting for funding, and in my country, we got about $300,000 to do the mapping for the whole country. So this was the first major sort of research work that I've been involved, where we conducted over 150 field surveys over a long period of time. And we have published this paper in Ophthalmic Epidemiology. This was a global trachoma mapping project. You can check on it. The last author, Anthony Solomon, is a chief medical officer responsible for trachoma at the WHO. So I've been working with him very closely. So what happened after we did the research was that we determined that Malawi had a list of around 6 million people from 12 districts. And our findings triggered the trachoma Malawi implementation for the first time, which was a program from 2014 to 2019, and it was funded by the UK government as well as the Queen Elizabeth Diamond Trust. And I was a PI for these surveys. I've been a PI for trachoma in Malawi. Every other survey that has happened in Malawi for trachoma, I've been one of the co-authors. Also in many other countries, in Ethiopia, I've done the evaluation of the trachoma program in Ethiopia. So what we did was that in 2021, we did the impact. We found out that at the start, there were 6,000 people that needed to have surgeries. And because the program had started, almost all of them ended up getting surgeries. But we knew all of them, we had done GPS coordinates, we knew where they were, so we were able to mobilize them and they all entered from the surgery. But by the end of the period, only less than 200 were at risk of blindness. When we did the follow-up surveys, it shows that the trachoma was below threshold. And when we did qualitative research methods, a lot of life has been improved in terms of the women that could no longer do their farming. They were able to go back to farming and they were able to make a living. What happened here was also that there was a global change in terms of the management of trachoma globally, because until then, WHO required that if you had a prevalence between 5 and 9.9%, you needed to look at the village level. And when we were doing the trachoma surveys in Malawi, we did find quite a number of these areas that were between 5 and 9.9%. And we proposed that why don't we try to give one round of antibiotic for the whole population for 1 year, and then we evaluate. And that's what came out. And I said, you see, Anthony Solomon is also there. The WHO gave us the money to do this study, and we demonstrated that where the prevalence is between 5 and 9.9, you don't need to go on the lower level. You can just treat the whole community, and the trachoma will disappear within 1 year. So this became a global policy, and this has helped up to scale up areas where they are not sure. You can just go and treat for 1 year. So here is what happened to Malawi in 2013 when we started. We had the prevalence of 1029 here, and the prevalence of 5 to 9. These are the ones that we did 1 round. These ones we did 3 rounds. So by 1 round, I mean once a year. 3 rounds, I mean you do annual MDA for 3 years. And in 2021, when we did the evaluation, you see that the whole area has turned green, which is less than 5%. And this shows you that the trachoma is no longer a public health problem. We submitted the dose of WHO as part of this research, and the experts, independent WHO experts, reviewed the findings for Malawi. And as you can see here, that the WHO validated Malawi as being the first country in Southern Africa to eliminate trachoma. And Malawi still remains as the only country in South Africa that has eliminated trachoma as we speak. And Dr. Pedros was able to give a certificate to the government, and I had a personal call from Geneva congratulating me that our research work in global health had contributed to more than 6 million people benefiting from this intervention. So this is where now the clinical trials started coming from. I might just say that since then, I become like a celebrity. But remember, this is just my 7th year after PhD, so I'm a mid-career in terms of research, but other people consider me as an older career because of my background in ophthalmology. But it just happened that Malawi was put on the map, and I started giving talks everywhere about how we managed to eliminate trachoma within a period of 8 years. And this is why now the clinical trial, which I wanted to speak about, came about. This is the mortality reduction after azithromycin therapy. We know that 2.8 million people under 5 children die every year, and in Africa, there's 73 deaths per 1,000 lives, and the commonest cause is pneumonia. But we also know that pneumonia itself is being treated by azithromycin as a first-line drug in most of these African countries. So when we were doing the trachoma work in Ethiopia, there were some observational studies that showed that when you give trachoma MDA, the under 5, the overall child mortality was reducing. And the hypothesis was made to say, could the azithromycin be protective for child survival? Gates picked up this. I know Gates, Bill and Melinda Gates, they really want the child survival issues to be sorted out. So they were already working in Africa, where they heard that there was a potential for azithromycin to be used in children. They said, why don't we do a clinical trial to see how we can do this? So this was a simple trial that was done in 3 countries, Malawi, Tanzania, and Niger. The trial was powered to 80% to get a 10% difference in mortality. The intervention was that we divide some of the clusters, we give them an annual azithromycin, and some of the clusters we give the placebo, and we see whether we can lower the mortality. This was a double-blind randomized clinical trial, which had about 1,500 cluster communities and an additional 90 clusters to see what would be the cause of the deaths. And the primary outcome was that in all-cause mortality in children. So what needed was that you do a census at the start, you give the azithromycin, you go back 6 months, you check everyone that you had census, and if they are disappearing in the census, you follow up. If they are dying, you record what was the cause of death. You use the WHO autopsy tool, and you determine the causes based on the numeric approach. And the secondary outcome was to look at what is the cause of morbidity. And this was a very tedious study. It involved around 190,000 children. And this, at this point, is when now I gave up the clinical. I was a PI for Malawi. I have to have over 60, 70 field workers. I have collaborators from kids everywhere calling me to make sure that things are happening on the ground. And for the sake of this study, I decided I'm no longer going to do clinical work. So this was the schematic approach of the study. Randomized the clusters equally into azithromycin and placebo. The intervention was to give the azithromycin every 6 months for 2 years, so 4 doses of azithromycin, and then to analyze the all-cause mortality that took place after 2 years of the intervention. We had some PhD students from London School working with me to do this study. What was the result? We determined, the result was powered at a global level for Malawi, Niger, and Tanzania. So the result was that there was a 14% reduction in mortality in the intervention arm versus the control arm. However, when you look at the country level, only Niger had a big reduction. Malawi, as you can see from the confidence interval, was not statistical significant, and Tanzania was also significant. I just want to say this because the study was not powered at a country level. The study was powered at a global level. And if you wanted to look at the sub-analysis, that was the challenge. We had over 1,500 depths, I think, in each country, but we selected a sample of 250 depths to look at what was the cause of the depths. And as you can see here, that for Malawi and Niger, malaria was the biggest cause, and for Tanzania, it was malnutrition. Pneumonia had gone down, so we don't know whether the deaths from pneumonia were presented or not, but that's what we observed. For those who may be interested, or those who may be interested in child health, this study was published in the New England Journal of Medicine, and it has attracted a lot of attention and criticism. This is to do with antimicrobial resistance, like azithromycin resistance, and so there has been some follow-up studies to try to quantify whether you can actually cause resistance if you were to introduce this as a child survival. So there are secondary studies. WHO has taken this evidence that indeed azithromycin can lower child mortality, but now they need to quantify it as to whether there could be a long-term resistance, especially of the strep pneumonia and E. coli. I'm moving on to the second clinical trial. As I said, I want to be very brief. This clinical trial now is on soil-transmitted hemorrhage. So, because I was involved in a trial on model, mortality, and azithromycin, and all of a sudden, Gates wanted to do another trial. And they put up a call to say, we are interested in 6 countries that may be interested to take up the trial. And I said, well, I don't work so much on this, but let me apply. And so I put up a case for Malawi to say, I've been leading this big trial on a model, and I've got the system in place. I would think we could have Malawi as a country to do this study. And guess what? Indeed, I was chosen to be a PI for this study. This is a multi-country study with many PIs, which I'm going to talk about. So what is the study about? We know that the soil-transmitted hemorrhage, they affect about 1.5 billion people. And how do they affect the 1.5 billion people? There are 3 species that are important to humans. There's Ascaris, or there's Ascaris. There's a whipworm and roundworm and hookworm. On hookworm, there are 2 of them. There is a Necata americanus and there is an Ancylostoma divitinale. When you walk barefoot and there is a hookworm or any other worms on the soil, you can have the worms, the lever of the hookworm can directly penetrate your skin, go to the blood, the heart, lungs, and lodge in the small intestine. For the whipworm and the roundworm, if you eat uncooked vegetables or you drink water that has got the hookworm, you can ingest the eggs. They can also go to the intestines. And in the case of Chichulia, they can go to the large intestines and they can cause rectal prolapse. In the case of the other one, they can go to the small intestines and they can start sucking on the blood. They mature into adults. They start laying eggs of 1,000, eggs, producing a lot of worms that is passed in the stools, and where there's a poor defecation and all that, then people ingest it again, and the cycle goes on and on. So because of that, you have impaired physical and cognitive development in children, stunting. You have reduced productivity because these people cannot get a good education. In the end, they pull out of school. And the WHO for the last 20 years, for all some of you know, have been doing a school-based dwelling. It's a very common program, all the countries. Here is what it's telling you, how many of the doses. So, for example, in Asia or India, over 100 million people are affected with hookworm. This is a global problem. It actually has a treatment. Treatment is albendazole or mebendazole, a single dose in a year. But what is happening is that since this program has been running on for over 20 years, there have been questions as to whether the school-based dwelling is an effective program. Why don't we scale up to a community-based where everyone else gets in? Because I talked about farmers who are farming rice. I talk about other people who get infected with the hookworm, but they don't benefit from the treatment. So this was the trial. The D13 clinical trial. Is it possible to stop transmission through a community-wide MTA? And this was a mixed method trial. As I said, the trial was done in Benin, Malawi, and India. The trial is in the final phase of being analyzed. Next month, we're meeting in Seattle with the Gates Foundation to disseminate the results. So there will be more of what is coming out from here. This is possibly one of the biggest trials that Gates has funded, because the total cost was $27 million. And the cost for my budget in Malawi was around $7.5 million. But it was a lot of work, a lot of work. So basically, school-based compared to community-based at the cluster level, still at the population level, 20 clusters per population, random allocation, and this is the schematic view of the trial. So school-based is a standalone, it happens once a year, so it was going to take place in 2018, 2019, 2020. The community-based were proposing that it should be twice a year because we believe once a year is not effective, so it was going to take 6 rounds of them. And after 3 years, we thought we can do a midline survey. By baseline survey, what we mean is we need to collect stools from everyone else, because the only way of diagnosing these worms is through sample collection of stools. So here we collect the stools to determine the baseline survey. At midline, we collect the stools. We assume that after 24 months, the ones in the intervention arm would have disappeared. And we also assume that once they've disappeared, they will not be able to come back. So we need to give 2 years of follow-up to see whether our hypothesis was correct. And as I said, I had over 20 field workers doing stool samples in the field. We collected over 60,000 stool samples, 60,000 in Malawi alone. An average of 500 stools a day, going house to house. And I had over 100 field workers collecting samples. So a massive amount of work that we have done. And as always, having some students. So Timothy Jones was my student, John Hart was a student, and they have published a paper on the prevalence of angelic parasites in children in Mangochi. Because we are allowed at a local level to publish our paper, but the overall results is going to be on the global level. So why did we add Imperial Science to the study? We know that it takes up to 17 years to just translate 14% of what is known to be beneficial for patient care. We know this is the fact based on David Chambers. So how can we ensure that more of the beneficial events are rapidly scaled up? So Imperial Science is the way. So here in the trial, we wanted to add Imperial Science to make sure that if at the end of the trial, the community-based master demonstration is proven to be effective, then we already have figured out how it should be scaled up. So we wanted to generate evidence for scale up at the end of the study. And we used the consolidated framework from Imperial research for those who are in Imperial Science. This is a CIFA, it's called by Laura Damshotla. We use that. And I can also talk to you in the afternoon if you want to understand what that is about. Through that, we were able to do stakeholder content research readiness surveys. This is the organizational readiness for change, process mapping, and cost effectiveness. So a whole range of studies taking place. And I may say that this study has been publishing about 12 papers every year since it started. 12 papers. Because we've got different people working on different angles. But if you are the PR on the ground, it means you are getting closer to 20 emails every day from different people. Someone is doing cost analysis, someone is doing this, someone is doing this. Everyone is looking for data from you. This is an example of the stakeholder mapping that I did. So we basically what we do is we have like informal workshop. We call all the potential stakeholders that may be involved in the WEM program. Then we start looking at what is their impact at the national level, departmental level, zonal level, district, up the community level. And we look at who are the ones that are pro and who are against, who are neutral, and what strategies you need to do if you were to roll out this. Because yes, you are moving from a school-based to a community-based. Some people in the government will say, we cannot do this. It's going to be too costly. So you need to have this information before you present it. So this is how you do it through the stakeholder mapping. And of course, you are going to be treating people in the community that are disease-free. So you need to have a quantitative research to discuss with how they feel about taking these drugs when they don't have the disease. And we published a policy paper on the global health policy, on the facilitators and barriers on launching this program if it's used to be successful. We hope that the trial will show that it was successful, but we needed this evidence to be there so that people can easily scale up once the trial comes up. And in terms of the cost, which I'm sure Professor Annie is interested, we knew that people asked to say, how much does it cost to move from the school-based to the dwelling, to the community-based? So we had some people who are doing economic analysis capturing all the costs. So we are able to capture all the costs for this study, and there's been a paper on how much it costs to move from the school-based to the community-based. So that's all in a nutshell. I know that I've read through. I want to summarize by saying that the global health interventions on NTD can lead to addressing inequities and improving social determinants of health, and that the strategies for NTDs are now being researched for other child survival areas. It's an exciting area. And that when you do hybrid clinical trials like the DWM trial, you can get this information from Imperial Science that will be needed when you find that the intervention is useful and you can easily scale up. Because you don't want to wait another 14 years before scale up. So we need studies on how this can be done. I believe I've demonstrated how my global health research expertise in mixed methods and research and Imperial Science has contributed towards the global overall of NTDs. So, as I'm concluding, there's always a question of what will I bring to UBC? But there's also the question of what will UBC bring to me? Because I said I'm already doing work. Even though I'm based in Canada, the study is still going on, I'm winding up. My family is here, but I've been going there, say, every 3 months, traveling, coming back, but I'm getting tired, and I thought, maybe I need to get something to do here. So I think in terms of what UBC can bring to me, after my research, I found that there's a whole range of expertise here that I could collaborate with, and we could do some of this work in other countries, the global health work. In NTD as well as in IHF if there was need. So that's what I think I can benefit. What would I bring to UBC? Well, I've been involved in 2 large clinical trials. So I'm sure I can teach clinical trials. I can teach in the Masters of Global Health. I can expose students to global health. Of course, this will need a bit of more funding. And I can also explore whether I could do some global health work within ophthalmology if they needed this type of work in India, in Asia, because I've got that expertise of doing large studies. In terms of research over the next 5 years, we believe that we need to design some more precision approaches for STH, because the map is showing that it's already everywhere. But when you go, for example, to countries like Bangladesh, where the program has been successful, it's not everywhere in Bangladesh. So how do you know which areas to target? So we need to find some ways of precision mapping. And we've been discussing with some teams from the Task Force for Global Health in Atlanta as to whether I could pilot some of the work here. And they said that they'll send me a proposal to have a look at it as to whether we can work into that. This could be part of the work that I can bring on board to UBC. Malawi has eliminated trachoma. We clapped hands. What if the disease comes back? We need to do some research to show that it doesn't come back in the next 3-5 years. And the Imperial Science and NTD, I could increase some visibility here because I said that I've got colleagues at the WHO who are working with me already. And if there were some grants within CHR or Canada, I could easily put up a proposal and get some funding. And also on my research, I've seen that there's quite a number of faculties that are working on the global health, Professor Spiegel, and a few other people. So I believe there's also Richard Lester, is working in digital health in Kenya. There's Videsh Kapoor, which is in family medicine, doing with students, and the students have already contacted me as to whether they can go to Malawi to do some work, and I'm thinking, oh, maybe I'll be here, maybe I'll be in Malawi. I'm still going through interviews. So there is a potential. And in terms of service, I think I could mentor a lot of the African students that are here to just give them some sense, whether they're from Ghana or Nigeria. I could go with them for lunch and all that. I know that it is extremely difficult to settle in Canada. So I could have a role in terms of the service if the vice accepted that that was okay for me. I don't want to take all the glory. Actually, I don't want to take any of the glory because, as I said, that I work with a big range of people. This is my team, this is my investor, but all these people are really on the group emails that email me almost on a regular basis. So I would like to thank them for believing in me and for continuing funding me. And finally, I would like to thank you, Professor Anis and Prof. Kube, for believing in me. I should say that since last year, I've knocked on many doors, written thousands of emails, been knocking, trying to send my CV to say, I do this. Is there a place where I could collaborate? And I've not been getting any responses. No response from email. But I did one day got an email from Professor Anis to say, your work on Imperial Science is interesting. You want to speak to us more about it. And that's how we started collaborating. And indeed, I'm pleased that I'm here now talking among colleagues that do global health. Because a lot of people ask to say, why does an ophthalmologist want to join a department of a professional department? But I think I've demonstrated to you that I've moved beyond ophthalmology. Thank you very much.
We have time for some questions. Not a lot, but at least some time. I'm sure there's time. I'm wondering if we should go to the remote listeners first for a question and then come back to this room. So anybody in the remote listening group have a question?
Can you guys see if anybody's putting up their hand or?
Yeah,
Two questions. So the first question is, Japan started releasing into the Pacific Ocean more than 1 million metric tons of treated radioactive water from the wrecked Fukushima nuclear plant on August 24th. The release of contaminated radioactive wastewater process can last 30 years. What are the implications for global health?
Jesus.
Is that the question for Professor Anis or for me?
I think these questions for you, but that might be a little out of your, yes.
I think that's a good one. Well, the first implication is that we need quite a number of PhD students to look at the impacts of those releases. I mean, there will be a whole range of health effects, that need to be studied. Any release into the ocean has the potential for contamination. It's not in my field to know what chemicals are in there, but indeed there is need to set up a team of global health experts in environmental area to look at this, because I don't work in environment, so I cannot give you the tiny details of that. But with all the media, and the things around, I could Google and find out what would be the impacts. But I'm not going to do that.
So the other question would be,
I go to 1 year.
you want to do one here?
We are alternate. Yeah.
Okay.
Yeah, David.
I'd like to congratulate you on your body of work. My name is David Patrick. I'm an infectious disease doctor who moved into public health. I directed the school some years ago, and I look after the research program for our Center for Disease Control in BC. I can see lots of connections with the work that you're doing. UBC hosts the only tropical and geographic medicine course in Western Canada, and I can see easy connections. And there's also another group across faculty that works on neglected global diseases that you may have heard about. But my question for you, Dr. Kalua, is this momentum that you've got on these large trials, are you planning or able to maintain that, or are you looking at a transition as you move to UBC? Because that is such a contribution and such a positive element of your profile.
Yeah, I'm actually looking for transitioning because I said since 2016, I've really been doing these big trials. And so I felt I'm transitioning to something that is more still on the global scale, but maybe not as large as these trials. So I'm transitioning unless there were experts who wanted us to do this in other countries. I'm more than happier to apply for those grants, but they do take a lot of your time, So I would like to transition to something that is manageable. Because at that time, I think I took this role of being a champion, but now I realize that it's too much. I need to be somewhere where it's comparable.
Well, by way of follow-up, then you transition towards what? What are there particular things that you're interested in doing?
Yeah, so I'm still interested in working in the neglected tropical areas. And also, if I could find some areas here for the First Nations Aboriginals to do with health, I would be very interested in that area because I've always been working with communities. And if there are courses for tropical diseases, I would be very interested in collaborating on those ones because I've got quite a big experience of tropical diseases.
Who's the question from?
This is from David.
Okay.
I guess David Birnbaum maybe, but given your international experience, what are your recommendations on balancing influence of external donor organizations versus legitimate interests and priorities of developing countries?
A good question that I did not cover, but in the 2020 to 2030 WHO NTD strategy, this has come up in the booklet that in the next 10 years, we need to do three things. As we scale up, we need to make sure that there is country ownership, and we also need to make sure that there is domestic financing. Because currently, almost all the work that is happening is externally funded. And there are very few countries like Malawi where there is a prominent local leader, but in most of the other countries, you have people sitting in UK, US, flying in, flying out. So I think WHO has noted that discrepancy that moving forward, we need to find ways on how domestic financing can take place as far as the NTD are concerned. So that's where we are heading to. How it's going to happen, we don't know because, as you know, the budgets in these countries are very limited. But there's a need to have some local financing towards NTDs.
Thank you. That's a good answer.
Okay. Congratulations on your talk, and I really enjoyed hearing about the comprehensiveness of your studies. And in particular, I'm interested in implementation science. And we've been talking a lot about implementation science at UBC and in the Faculty of Medicine. And I'd like to hear a little bit more about your studies, how you put those in place, and how you might continue, what your plans are in continuing that work, or if you plan to continue that work into the next phase of your career.
Yes, I'm very interested in imperial science, but to say that imperial science takes a lot of time, it needs a lot of dedication. So you cannot do imperial science on a larger scale like it is. So you need to design very good questions. You need to test a range of theories for scale up. So it would be interesting for me to extract some of the lessons that we have learned. As I said, next month we're going to be discussing the study with the Gates in Seattle on the 12th of September. And there's already this question of what is next. Because there's a belief that the intervention will show that it is effective. So that imperial science work, I'm interested. I'm not sure how much, I was trying to say here, how much imperial science is taking place here, but it's a lot of work that needs to be dedicated, but I would be interested in pursuing that area if there was need.
Thank you.
Mike.
Thanks, really enjoyed the presentation. I have two questions. One on the teaching side, just wondered on your thoughts for us on relative perspectives of emphasis on NTDs versus NCDs for LMICs, especially in Africa. And the second question would be related to NTDs. Have you done any work on the impact of climate change and how that might relate to future trajectories?
Okay, the first question, NCDs are becoming very common in Africa and all the other developing worlds. So that's an interesting area that needs to be focused on. But the issue is that the NTDs, I can use the word, they're a nuisance. They can't be taken care of very quickly. Whereas NCDs, they need much more time. So if the effort was done as the WHO is trying to do it, to say, let's get over these NTDs, then we can focus on doing NCDs. In terms of the climatic studies involving NTDs, the issues that I'm aware of is always the disposal of these, when you do MD, how do you dispose these huge amount of bottles of stromycin? What are you doing to the environment? So there is some protocol on it, but there hasn't been very extensive studies on climate and NTDs. Right now, people are talking about geospatial mapping. They are looking at how can we predict which climatic areas are more likely prone to NTDs. This is increasing interest in a lot of people. So if people have got expertise in geospatial mapping, especially for soil transmitted heavens, I think they would like to link the two to see whether we can figure out or predict which areas based on the climate, because they are related to climatic changes.
Any more questions online?
No, I think we should just, we can do the questions later on in that designated question time.
Yeah.
Yeah.
Okay, any last minute questions? Okay, our minute.
Hi, I have one. Thank you very much. I enjoyed the presentation. My question is about the pharmacology, the pharmaceutical companies. You had some partnerships there, but specifically to trachoma and reducing all-cause mortality. The availability of the antibiotics is key. And how would you, or did you have a role in doing it historically in the years you were working on it? And how would you, if not, how would you initiate it here?
Yeah, so among the people that are dealing with the NDDs, there is a group called NNN, the National Disease Network, which has got academics, pharmaceutical companies, governments, and the WHO. And among these pharmaceutical companies, there is a Pfizer, which makes the azithromycin and has played to give the drug as much as you need, as long as you need it. We have ivermectin done by Merck. It is also played to give the drug for quite a long time. We have got albendazole that is being produced by GSK, who has also said that they will give as long as it's needed. We have got mebendazole is being produced by Johnson & Johnson. I'm aware that they're committed up to 2025. And so, and then it looks like pharmaceutical companies would like to invest in this area. So, donated drugs have not been a major challenge as far as the entities are concerned. The pharmaceutical companies are willing to donate them for a longer time.
Thank you.
Okay, thank you very much. Let's thank Dr. Kalua once more.